Hello everyone. Hi. We do have some that will come a little bit later due to flight delays, so please bear with us. You will hear lots of traffic coming in, and we'll try and have it be quiet for you. Good afternoon everybody, my name is Kelly Hayes and I'm the Nurse and Manager of the Hepatitis Foundation. Welcome to our conference. A few housekeeping matters to attend to quickly before we get underway. Information from Te Papa regarding health and safety. If there is a fire evacuation, continuous sound of the fire alarms will be activated all throughout the building, and all occupants should leave the building immediately. The fire exits are located to your left and through the entry that you came in. Te Papa Museum hosts will take full charge of the evacuation and will ensure the building has been fully evacuated. The assembly point is in front of the Te Papa Museum near Suka Theatre or Barnett Street corner, Cable Street, next to Waitangi Park. The Te Papa hosts will advise all guests when the building has been cleared for re-entry. If in the unfortunate event of an earthquake, please find cover and remain until all tremors have finished. Should the alarm go off during an earthquake, please remain in the venue or follow instructions from the Te Papa Museum hosts. Smoking. Te Papa Museum is a non-smoking environment. Smoking is only permitted outside the confines of the building and away from the main entrance doors. Toilets for your personal use. These can be found first on your right as you go out here, and also straight ahead, you may have noticed when you came in. For your coats and bags, you may have already found that there is a room we have put aside for you for your bags, so you can keep it nice and safe in there, and also tomorrow that room will be available as well. We also have coat racks for your use if you need them. Mobile phones, can we please ask that these be put on silent mode or off during presentations? For car parking, there is a parking validator available for those who are parked in the Te Papa car park. Please see Jackie Elms or Linnea Matthews, who you met when you came in and registered. They can help you with anything to do with this. Internet access, there is complimentary Wi-Fi internet service to all function attendees. Please see the whiteboard out by the registration desk as well. Our presentations conclude today at 5 o'clock. We have drinks and canapes available until 6 p.m. at the back of the conference room here. A message from Te Papa, no food or drinks are to be taken outside of the hired venue at all times. And lastly, those of you staying at the Travel Lodge this evening, there will be 6 shuttle vans with trailers outside Te Papa main entrance from 6 p.m. to take you to the hotel. Please see our nurses Gillian White and Jackie Seawood, who will help ensure 11 people get on each shuttle bus. A request from the hotel reservation staff, please be patient as there is 61 of you checking in at the same time. For your information as well, breakfast is included in your stay and this starts from 6:30. Be mindful that we do have shuttles picking you up at 7:45 a.m. As we need to start at 8:30. Any questions, please don't hesitate to find me and I'm more than happy to help you. Thank you, and I hope you all enjoy our conference. I'd like to introduce Dr. Alex Lampin-Smith, our Clinical Director, to say a few words. Thank you.
Tēnā koutou katoa. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Nā mihi nui kia koutou katoa. Ki te atua, tēnā koe. Kia papanuku, tēnā koe. Ki te whare, tēnā koe. Ki te hanga mate, ki te hanga ora, tēnā koutou katoa. Welcome. As Kelly said, I'm Alex Lampin-Smith, Clinical Director of the Hepatitis Foundation, and on behalf of Susan Hayes, our CEO, who can't be here this week, and Kelly and all of our staff at the Foundation, we'd like to welcome you to this meeting. We are very pleased to be hosting this event. Chronic hepatitis B and C are common conditions in New Zealand, and they affect approximately 150,000 people here. For the majority, these conditions are relatively asymptomatic, so these people may not experience much in the way of side effects or very vague or non-specific side effects, so many people may not be aware that they carry these conditions. Over many years, these viruses can cause problems in the liver, and a significant proportion will go on to develop the complications of these diseases and have poor health outcomes such as liver failure, liver cancer and premature death. The Hepatitis Foundation is a charitable trust contracted by the Ministry of Health to run a monitoring program for chronic hepatitis B. With regular monitoring, it is possible to identify those who may be developing complications of the diseases and to facilitate further assessment and treatment where applicable. We have approximately 25,000 people on active monitoring, and we also provide advocacy and support for people with hepatitis C. Over the last 10 years, there has been groundbreaking advancements in the management of chronic hepatitis B and C, and internationally the focus is now on removing these viruses as health issues. The movement in this field has culminated in the World Health Organization declaring the goal of eliminating viral hepatitis as a public health threat by 2030. In the New Zealand context, achieving these goals will come from the community. We don't need more hospital hepatologists for this. We need more community healthcare professionals who are interested and able to manage hepatitis B and C. So it is on that note that I'm thrilled to see so many of you here. We have a mix of primary care, GP practice nurses, prison nurses, and a few hospital-based specialist hepatitis nurses. Community-based healthcare workers in New Zealand are incredibly stretched. And as a hospital specialist, I want to reassure you that we know that you're being stretched a long way, and to be given another chronic health condition to be asked to manage might be daunting. And we want to support you as you embark into this field, which will be new for many of you in primary care. It may sound a tad dramatic, but I think it is true to say that it's the people such as yourselves in primary care who are going to make a difference for the thousands of New Zealanders affected by these viruses. I'd like to sincerely thank AbbVie for supporting this meeting. Without industry partnership, this educational meeting would not be possible. We have Jill down the back representing them, and David will be coming a bit later on. And I would encourage you, if you have any questions about Vicaripac treatment in your clinical environment, to liaise with them. You will see a number of people in the audience wearing lovely green t-shirts. Stand up, all the Hep Foundation nurses. These are our wonderful, very experienced community-based hepatitis nurses from the Foundation. And we have one or more of these nurses covering most regions of the North Island. Our offices are based in Whakatane, and we have stationed there a very experienced group of administrative staff, and representing them here when they get in on the Auckland flight, which is there will be people arriving in the next wee while, are Karen and Amanda. Our administrative staff are incredibly knowledgeable about hepatitis B and C and the systems and processes affecting their care around the country, so please drop by the stand for any questions relating to that. We also have the business cards for all of our community nurses, so feel free to grab those for the ones applicable to your region. I'd like to acknowledge today that our hospital-based nurses are on strike, and I think that's a really important thing that they're doing that. And there are some hospital-based DHB employed nurses who are here, so acknowledge that you're here and you're striking. Thank you. So as we get into the education sessions, I would encourage you to write down any questions that you have. We want to keep this relevant for you, and so we aim to have question time usually be at the end of each talk. So without further ado, I'd like to introduce our first speaker. Dr. Chris Moyes is a graduate of the Cambridge University. Chris specialised in adult internal medicine before changing over to become a paediatrician with a particular interest in epidemiology and preventative medicine. In association with Sandy Milne, Chris defined the epidemiology of hepatitis B in New Zealand and conducted several of the early vaccine trials. Chris holds a Royal Australasian College of Physicians Medal for outstanding service in a rural community and has been the Hepatitis Foundation's medical director for more than 20 years. And what I've heard said about Chris Moyes is what he doesn't know about hepatitis B isn't worth knowing. He's just that experienced. So, Chris, thank you.
Thank you very much. Now, I would like to apologise to those of you who've seen some of these slides before, or to whom some of what I say is going to be fairly basic, but I see my role today is to set the scene, and that necessarily means reviewing some of the basics around hepatitis B, and I hope you'll forgive me for that. So if we look at what hepatitis B is in terms of its importance, it's one of the world's most common infectious diseases, with approximately 350 million people worldwide infected chronically with it. And something like 500,000 to 1 million of those die each year from its complications. The virus itself is seen in an electron micrograph in that slide. If we do it diagrammatically, you will see that it's got a DNA core. It's a DNA virus, unlike HCV and HIV, and that's important. I'll explain why in a moment. It's also got various other proteins that we can identify when we do the markers. So there's an outer coat, which is surface antigen, which of course is the marker we use for identifying hepatitis B carriage, and is also the basis, when synthetically remade, of the current vaccines. You will notice that I've put in the diagram that there are little capsules of hepatitis B surface antigen which don't contain whole virus. And in fact, these are secreted in very large excess into the blood. So biologically then, it's a DNA virus, which makes it much more resilient than RNA viruses such as HCV and HIV. It means, for example, that you can dry it and it's still infectious. So that it's possible to get hepatitis B by scraping your knee in a place where another child scraped theirs a week or two before. This is quite different from hepatitis C virus or HIV. It produces that vast excess of surface antigen in order to suppress the specific immunity of the body and persuade the body that it doesn't have a foreign protein there. And once chronic, it lasts for many years. So those are the sort of, and it integrates its own DNA at some point into the host's DNA. So that in fact, once you've been a chronic carrier of hepatitis B virus, even if you apparently get rid of it, if you do really detailed PCR of bits of liver, you'll find that it's still got sequences present in the genome. And it has a very resistant form, which makes it very hard to eliminate, and explains why the current treatments that we're using don't eliminate the virus, but just suppress it. And I think there may be some further discussion of this, either from Frank or Ed later in the program. I'm not going to talk about that. So transmission of hepatitis B, how come it's so common for a start? Well, most commonly it's blood to blood, but as I've said, it can be from dried blood. And infected serum has a huge infectious load of virus. I remember Sandy Milne in the old days, he was the laboratory side, used to say that using the very insensitive tests that we had 30 years ago, that he could tell from some water in a swimming pool, if somebody with hepatitis B had been in it, that might have been an exaggeration, or bled into it, I should say. That might have been an exaggeration, but it indicates that how potentially infectious it is. And most of the children we see, or used to see, that were infected, are running titers of virus in excess of 10 or even 100 million particles per mil. And a mill's about the size of the end of your little finger. So it's a huge amount of virus that they're running around with. I said it's resistant to drying, and so crusts of sores remain infectious. And can then enter abrasions from other people. And you can imagine how a kid with school sores on the mat can transmit it to another child doing the same. Transplacental spread during labour is another important source of infection. And there's some evidence that that carries a worse prognosis. So that's what we sometimes call vertical or perinatal transmission. It's also transmitted by semen between adults, but it is not effectively transmitted by poor hygiene when it comes to washing hands, for example. And I'm currently in a spat with one of the meat companies who are trying to stop people from working on their meat chains if they've got hepatitis B, because it isn't transmitted that way. So we think, if you look at the kids in our area, most of them seem to run around with bare legs and bare feet all the time, scuffing themselves on concrete. As I say, they sit on the mat as well, and you can imagine how they could transmit the disease. Now, what happens when you get transmission is very dependent on the maturity of your immune system and also the dose of the inoculum. So that if you're infected from your mother at birth, transplacentally, then the great majority of those children would become chronic carriers. If you're infected at the age of a year, it's about 30%. And it gets less, and actually that solid line should be lower than that, because most of the good, large retrospective studies indicate that in healthy adults, below the age of about 60 anyway, it's probably less than 1% become chronic carriers, or 1 to 2% at the most, but you will see 5 to 10% in the literature, which was based on some erroneous data many years ago that nobody's ever bothered to correct and just keeps getting churned out again. But adults don't normally become chronic carriers unless they're like me and they're getting aged and their immune system is dropping off a bit. And in geriatric homes, you can get carriers. In the adult who is infected, and it is much more likely that you'll get acute infection, as we'd call it, acute icteric, i.e. jaundiced hepatitis, where you get yellow and you get sick and you get dark urine. While a lot of them are asymptomatic, the substantial proportion actually are symptomatic. But the reason why they have that response is because their immune system is recognizing the virus as a foreign agent, and it is getting rid of it by destroying the cells that are infected, i.e. the liver cells. And that's what makes you sick. So unless you do something silly like give steroids, which they used to years ago, to people with acute hepatitis, then in fact they don't become carriers, they get rid of it. So it's a different condition. So what are the high-risk groups that we've got? Well, the individuals most at risk of developing chronic hepatitis B then are infants, particularly under the age of 3, and I'll show you some figures on that in a moment. Those who get infected from their mothers by transplacental transmission at birth, something which should be almost totally preventable in New Zealand now. And immunocompromised individuals can become carriers as well. So in New Zealand, before we had vaccination, what was the pattern of illness? Well, the story actually started when our laboratory charge nurse, who was, or charge technician Sandy Milne, came to me and said, we've just got some, we get a terrific amount of acute hepatitis around this place, a lot of it in young people and children. Nobody seems very interested, and everybody's assumed it's hepatitis A, but we've just got some kits that can test for hepatitis B, and I've tested them, and they're all B. Well, they weren't all, but nearly all B. And that was really the beginning of the story of us starting to look at this. And we looked at quite a lot of populations, but we looked in particular detail at the population of Kawerau, which was a town at the time of about 8,500 people, which was very easily definable geographically, and a lot of them were very accessible through things like the main employers, the pulp mill and so on. And we went out with research money, and we bled 94% of the population of Kawerau, which is quite a story in itself. And there is someone here, Helen, who was part of that. And she's been in this story right from the beginning. One of the characteristics of Kawerau, compared to many other places, is that it had a fairly even mix of Maori and Pākehā. A few people of island origin, but mostly Maori and Pākehā, who were very integrated. And that was reflected in the results, I think, that we got when we looked at it. So when we looked at people who had markers of past or current hepatitis B infection, this is not carriers, this is people who've been infected and either developed antibody or become carriers, and added them together, what we found was that by the time the children in Kawerau were getting into their early teens, roughly 80% of the Maori population had been infected. And very unusually, nearly 70% of the Europeans. There are other places around the world where you, like Fiji, for example, where you get very big differences between the two races. But this was a reflection, I think, of that sort of integration in the schools and the preschools. And you'll see that most of the infection occurred during the preschool and early school years, obviously in very innocent ways. And if we looked at the prevalence of carriers, this is people who are chronically infected, then what we found was that there was quite a lot higher. It was about 5% in young Maori, but fell off. 20%, 15-20% in young Maori, and 5% in Europeans. Very high figure for Europeans. Those graphs fell off. Now, there are two possible reasons for that. One of them was that things had changed with time and the infection was getting more frequent. The other is that people lose the carrier state with time. It's not necessarily a lifetime thing, even though I said that you could still detect genetic traces of the infection many years, even when they've lost the markers. But as far as surface antigen is concerned, there's a reduction in adulthood of about 1% a year lose the carrier state. So that was what we found there. And we looked, I haven't put these figures up, but we looked at the whole Eastern Bay of Plenty. And what we found there was very much the same in terms of by the time children were in the secondary school, that there was about 15 to 20% of Maori males and about 10 to 15% of Maori females were chronic carriers, and about 5% of European males and 2 or 3% of females. And I would suspect that the genetic differences, the gender differences were a combination of the fact that females are more immune competent. They pay the penalty, of course, with autoimmune disease, but they are more immune competent. And the fact that I think boys' play has probably a greater tendency to be rough and ready. You can decide for yourselves which of those is the most important factor. So based on that, we then started to recommend giving universal vaccination to infants. And we did, and were part of a big national catch-up program in the late 80s to test all the children in the North Island, or offer testing, and to vaccinate those who hadn't been infected in the past.
When did the vaccination come out from?
Sorry?
What year did the vaccination come out?
The vaccine, the original plasma vaccine came out in, I think it would have been about 1982, 83. We had an international meeting when we got these results with some very key figures, including Saul Krugman from New York, who was the first person ever to make the vaccine and in fact gave it to himself to check its safety. And with one of the big vaccine firms, Merck Sharp and Dohme in particular, but we also got involved with SmithKline French, as they were in those days, doing vaccine trials. And originally the vaccine was incredibly expensive, and it was visualized it would mainly be used for medical people to protect them. We managed to show that you could get away with 5th or 10th recommended doses in children and get a good immune response. And we did that, in fact, in the Bay of Plenty, and then it became a national program. Yeah. I think we were giving universal infant vaccination from about, I don't know the exact year, 85, 86, and we did the catch-up in about 1988. Sorry, if you wanted more precisely, I'm sure I can look back and find out, but I don't remember the exact year. So that was the story. Now, what is the natural history then of a hepatitis B carrier once they become a carrier? Now, if you forget everything else I say, I would like you to remember this slide, because it's the key to understanding what chronic hepatitis B is about. It's actually slightly out of date in its terminology. You will see that there are 3 phases referred to. On the left, immune tolerance, that's still called that, I think. Immune clearance, that's really immune active. And then you can get either inactive or active later disease. So what happens is if you get infected and become a carrier as a young child, well, as I said, the body doesn't recognize the virus as being foreign. And because the virus is itself, in these circumstances, there are some special circumstances when it can be directly damaging, but usually it's not directly pathogenic. So you can have these vast amounts of virus in your system and be as healthy as, bright-eyed and bushy-tailed. It doesn't mean you're sick at all. But you've got a large amount of virus in the system, and as I say, many, many millions of copies in each ml of blood. Then, usually what happens is at some time during your life, your body becomes aware of the fact that it's got a foreign antigen there that it shouldn't have. This often occurs in the late teens or in the 20s, but it can occur at other ages as well. And then it starts to try and get rid of the virus by destroying the infected cells. And this is when you can get active hepatitis, where the liver is getting damaged. And it often occurs in rather irregularly. You can see there, if I just go through this. So the first phase, whoops. Where's the... No, not getting that. At the top left, the first phase, you've got a very high viral load. At this point, the E antigen, which corresponds approximately to a high viral load, is positive. But your ALT is relatively normal. I use the term relatively. It may be 30, 35, which actually is high in children. It should be less than that. But it's not, it's very, very low grade inflammation. You then get a period which may or may not be clinically apparent when the ALT goes up, and it may fluctuate in those waves. And at that point you can get damage to the liver and it can scar. But in the young person, that scarring will usually resolve when you go into the into the third phase. In the third phase, the amount of virus in the blood has diminished to a tiny fraction of what it was and may not be detectable. There's anti-HBE present and the ALT settles down again. But by this time, you've got residual integrated hepatitis B in your genetic, in the genetic code of your liver. And the virus, very characteristically, in many people, actually becomes resistant to the immune, or partially resistant to the immunity, and then you start to get a chronic dogfight between the virus and the immune system, which and the liver is the site in which that happens, and you get very often a mutant virus, and the ALT goes up again. Again, it may fluctuate, and this is when you start to get permanent, typically when you get permanent scarring. Now that's very broadly the natural history, and we'll talk about HCC in a moment, but just in terms of actual scarring of the liver, which can progress to cirrhosis, that's roughly what we find. Does anybody want to raise any issues about this particular diagram? Okay, we'll move on for the moment, but if you want to, ask me afterwards or at the end of the talk. So, what's the morbidity? Well, you can get liver failure. It's not particularly common, but it does occur. And you can get hepatocellular carcinoma. And we attempted to estimate the frequency of this some years ago. This is all based on some presumptions, but we thought it was about 1 in 6 of males who were carriers amongst our Maori population, and less in females. and it gradually scars up to form what we call cirrhosis in its more severe form. And cirrhosis can lead not only to liver failure, but to all sorts of nasty complications that Alex could tell you about, with portal hypertension and esophageal varices and so forth, as well as hepatocellular carcinoma. Now, hepatocellular carcinoma occurs mainly in those who've developed cirrhosis, not entirely. About 1/5 or something like that of the hepatocellular carcinomas occur in livers that are actually not seriously scarred, may not be scarred at all, because the hepatitis B virus has an adverse effect on the oncology control of the genome. So you can get it. In Asia, they certainly reported them in kids in the first decade of life. I've never seen that, but we certainly had people in their 20s, for instance, develop it, who've had otherwise blameless livers. But much more commonly, it's in those who've developed advanced liver disease. And the importance of this is that our main job is to stop people getting advanced liver disease and cirrhosis. We've got a supplementary job of trying to screen them for early cancer, but the main job is to stop them getting there in the first place. And if you look at the incidence of hepatocellular carcinoma, it just corresponds to those areas of the world where we know that hepatitis B is commonest. Of course, it can occur with C as well and various other things, but it's striking that it corresponds so well to hepatitis B. Right. Take a pause for breath. And then I'll go on with hepatitis serology. Okay. So, if we're looking at hepatitis serology, I'm not going to go into this in any detail, but if you get the slides afterwards, it will include one that I'll show you briefly that tells you what we do at the Hepatitis Foundation. But if you look at the commonest serological markers that you're using, the bog standard marker for deciding if somebody is a carrier is surface antigen. And if they're surface antigen positive, and they're surface antigen positive 6 months later, they are by definition a carrier. HBe antigen is present when in the early immune tolerant phase, and usually implies a very high viral load. One of the more expensive tests that we do is HBV DNA, which is a viral titer. Except in certain circumstances, like when we're trying to measure a response to treatment, for example, I don't do that on people who are E positive, because I know damn well it's going to be very high. It doesn't tell me anything I don't know. Anti-core is often done because that signifies past natural infection. So it's obviously present in all carriers, and it's present in most, though not all, because it can disappear as well, of those who've been previously infected and got over it. IgM anticore is a bit that indicates either that the patient's got acute hepatitis or that they've got active hepatitis anyway. And anti-HBs is a measure of immunity in vaccinees. But its absence, and this is very important, we're not really talking about vaccine today, but one of the common questions you get asked is, my child had the full vaccination as an infant, and he's now 15, and we've done an anti-HBs and it's negative, what should I do? The answer is generally nothing, because the immune memory in hepatitis B, this is not true in all vaccines, by the way, the immune memory in hepatitis B far outlasts measurable anti-HBs, and it protects against infection. So actually you don't need anti-HBs. If you know somebody had a full course of vaccine as a child, they're usually fine. There are exceptions because there are people whose occupations, like in the medical field, are going to want, their health and safety people are going to want to know that they're immune to hepatitis B. And in that situation, you may give a booster to chase things along. But anti-HBs, if it's present in people who've been vaccinated, it means that they're still immune. But its absence doesn't mean non-immune. And by the way, it's sometimes present in carriers too. So you still have to do the HBsAg. Now that's the slide I am not going to go through. It's far too busy, but it'll be on the slides if they're circulated afterwards, or if you want it, you can get it from the Hepatitis Foundation, because that's our sort of general what we do with different markers and the things that we test and when we retest and so forth. So that just gives you an idea. Talks about this, the ALT, how often do you have to watch ALT. It talks about some of the other liver function tests. Now, one marker that we use, which has got a more specific reason, is the alpha-fetoprotein, or AFP. Alpha-fetoprotein is commonly raised in pregnancy, and the first question you ask if it's a reproductive age female is, could you be pregnant? But once you've excluded that, what does a raised ALP above 25 mean? Well, we normally do them whenever we're doing the routine follow-up surveillance blood tests. And in the particular series that I looked at, nearly half of those who had a raised AFP had hepatocellular carcinoma. A slightly greater proportion, it was just part of a flare associated with high ALT and so on. But you do have to take it seriously. I think that's what I'm saying, if you get that, and that's why we do it. The risk of, I'm not going to talk further about how you manage that. Frank will talk about that, I think. But I'm just going to talk a little bit about the risk prediction for hepatitis B carriers. Do you know who's likely to get it? Well, I've already said cirrhosis is a major risk factor, and I'll show you a figure on that in a minute. Age is a risk factor. As you get older, it increases exponentially. Gender, males are much more prone than females. Viral level prior to treatment is very relevant, and I'll show you some information about that. Other factors that are not normally considered but are very important actually are family history. If anybody else in the immediate family has had hepatocellular carcinoma, that significantly increases the risk. Diabetes or fatty liver, which is very common, and alcohol are cofactors, but they don't increase it hugely. Again, I can show you some. Now, I'm indebted to Ed Gain for these slides, which I nicked. There was a very big study done in Southeast Asia looking at a huge number of hepatitis B carriers and who developed advanced liver disease. It was called the REVEAL study. Most of these did not have liver biopsies or any assessment of liver fibrosis as such. So it was an attempt to look at risk factors just on simple bloods, really, and demographic stuff like age and sex. One of the striking ones was that the people who had a high HBV DNA, we're talking now predominantly about HBe antigen negative older people who had, and 10,000 is quite high for that group compared to millions for the E positives. And you'll see that the risks, the adjusted risk rate, which is ringed at the right there, increased considerably with the HBV DNA. So a high HBV DNA is a significant flag for risk. And that's shown again in terms of some graphs there showing with each thing, with years of follow-up, the risk for hepatocellular carcinoma increased. Same again. So when you actually boil that down to statistics, now you can see what I mean, that things like alcohol were significant, but they only increased the risk relatively little, whereas an HBV DNA that was high increased it many times. And particularly in the E negatives, who are the majority of the ones we're talking about, it increased it vastly. And cirrhosis increased it by a factor of 9-fold. So those are big flags for risk. Based on this, they developed a risk score, which we're starting to use and sometimes to put on our letters, particularly to secondary care specialists, of potential risk. Now, this is from Southeast Asian community, may not necessarily apply exactly in our community, but we think it's the best model we've got. It doesn't include cirrhosis, as I say, which we know is a significant major factor in its own right. But and I don't want you to remember that. It just shows you how you score it, and it can be done on the computer automatically. And then it gives you the risks with different scores of developing liver cancer. And you'll see at the highest risk level, you're talking about 80% at 10 years. And at the lowest risk, it's less than 0.3. So that may be a tool in the future. Now we're freeing up treatment that may help us to discriminate between the people we need to treat and the people we don't need to treat. With treatment, what's the risk? It's defined now by the degree of residual fibrosis when you start treatment, and can be scored by a modified reach where you use a fibroscan, for example, instead of a viral load. Now, there's a lecture later on about fibroscans, their snags, their advantages, and so on, I'm sure. So I won't go into that at the moment. But if you know that somebody has got established fibrosis, they are still at risk of cancer, even if you've treated them effectively. But the risk diminishes progressively. Let's see, yeah. So that it goes down by a factor of about a quarter per year, and that's cumulative for the first few years of treatment. So we know that in the long run the risk of HCC is significantly diminished. But it's not absent. If you had significant liver disease before you start, you're still at risk. I think I've exhausted myself with that. I'll finish there, but I'm very happy to answer questions.
I suppose the thing that I always get asked or in discussion, which might... hello. Hi, everybody. I suppose one of the questions I kind of get asked, or that may be a bit confusing for some of the nurses, is the word carrier, because, and especially with patients, you go to visit a patient, they say, well, I've been told I'm a carrier, and that's all them, and they get this concept in their mind that if they're a carrier, they aren't really hepatitis positive, if you know what I'm talking about. So can you just have a bit of discussion around the word carrier?
It's really, yes, I mean, whether it's a good word to use these days, I mean, you can talk about chronic infection if you like, but lay people also use the word chronic in rather different ways. Sometimes they actually mean acute when they say chronic. Oh, it was chronic, doctor. I don't know the best term to use with patients particularly. But I think it's a really difficult balance between getting patients to take their condition seriously and recognise that they need to have surveillance and follow-up, and yet, particularly in certain communities, not panicking them that they've got something terrible. Because after all, if you analysed people in this room, forget hepatitis for a moment. I don't know what the figures are. Alex might be more informed than I am, but probably nearly everybody would have CMV in their blood, cytomegalovirus. Most of us who've had chicken pox will probably still have varicella, which is why we remain at risk of shingles when we get old. So the concept of a virus sitting in a fairly dormant state in the body is actually, it's not just hepatitis B. There are a lot of things. I don't know, do you like the term carrier, Alex, or do you prefer to say something else?
I think it's better to say chronic inactive infection or chronic active infection. So the person knows that they have the infection. And
Yeah, they've got to understand
define
what the
for
word
them whether
chronic
it's-
means too, though.
Yeah, absolutely. So a patient, without the education that we can put forth, it's explain to the person you have the virus, and in your situation it's inactive, but we will continue to monitor. And if a person is showing signs of active infection, i.e. the ALT is up, then that's when we need to talk about further assessment and consideration of treatment. So the word chronic inactive infection or chronic active infection, I think, better than carrier.
Yeah, because I've always got hepatitis either way, and I think a lot of patients seem to believe if they're a carrier, they have. Yes.
Well, yes, obviously there's a lot of confusion between the different hepatitides in the lay mind as well, which has got to be. Entecavir is a very good treatment still, yes. I mean, I don't know if, Frank, you're going to talk about that about it later at all. There is a lot of research going on at the moment to try and develop curative drugs for Hep B. At the moment, the treatments are either interferon, which has a lot of side effects but is time limited and doesn't work very well in our population on most of the E negatives, but sometimes is quite a suitable thing to try in the E positives. And a few of those will effectively cure in the sense of getting rid of surface antigen. But generally speaking, the treatments available to us, particularly for the E negatives, are entecavir and tenofovir. And they're both drugs that suppress the virus extremely well and prevent further liver damage, but they don't get rid of it. And nearly all, if you stop it, you'll get a resurgence when you stop it of the disease. The one time when you would stop it is if you started them when they're E positive and they become E negative and develop anti-E, because the body's immune system has done its own thing there, and you can often get away with stopping it. But if you started on an E negative patient, my current feeling is that they should stay on treatment for life, probably in most cases.
And is there still problems with the resistance?
Not much. If they haven't had, we used to have some problems if they'd had lamivudine, that was Zephyx, because a lot of the viruses became resistant to Zephyx, and there was a cross resistance with entecavir. so that quite a lot of those people didn't respond very well to entecavir. But Zephyx isn't used much these days, and probably won't be used at all, I would think, from now on. But it's a good drug, just not a cure.
Any other questions about hepatitis B?
Okay, thank you.
Chris, thank you very much. All right, so our next speaker is my colleague from Hamilton, Dr. Frank Wylett, gastroenterologist and hepatologist. He trained at the Austin Medical Centre's Victoria Liver Transplant Unit in Melbourne and in advanced endoscopic techniques and imaging at the California Pacific Medical Center in San Francisco. In 2011, he was awarded the 2011 American Society for Gastrointestinal Endoscopy Cook Medical Don Wilson Award. It's a very big name. And he's here to really get into the meaty topic that really excites the hepatologist, which is cirrhosis and liver cancer. So it will be a really interesting clinical talk. So thanks, Frank.
Thanks, Alex. I'm sure you all want to know about Hep B and C, but when you've done it all and cured it all, we're still going to have this issue. And this issue is really going to be with us and be a significant part of our clinical workload for the next 30 to 40 years until we've actually removed these viruses from our community. So I was given some learning objectives, and I'll just list those for you. And I'll try and fulfill as many of those as I can so that you can get a good grounding. When I wrote this talk, I wanted to try and pitch it at the right level, so some of you will think that's too basic, but I have kept it very basic, and I will base my talk around case studies so that we can get learning points from those. The reason why we care about cirrhosis, it does impact longevity. So for those patients that have compensated cirrhosis, even though the death rate at 1 year is only between 1% and 3%, it is still significant if you add that over the years. And certainly when you have decompensated liver disease, your death rate is very high, as much as 60% within 1 year. So it does matter. The second thing why it matters is that it's an increasing burden. And if you look at these two graphs just for hepatitis C in the modelling, we can see that cirrhosis is increasing and the burden of liver cancer is increasing. And that's reflected in the modelling of where we're going to spend our money. So you can see the modelling until 2050-60, most of the money is not spent in the treatment, which is down the bottom, but it's going to be in liver transplantation, liver cancer and cirrhosis. So that's where the money is going to go. And that's because the burden, how expensive it is to look after patients, and what that means is we need to prevent it, obviously. So I got all these pictures from Google, so if you recognize any of the faces, I just made them up, right? But I'm just going to use some case studies. So this is a 60-year-old lawyer. He's married with 3 children, and he's coming in for his 2-year health check for hypertension, cholesterol, and diabetes. And he admits to a little bit of social drinking, but he's found to have abnormal liver tests. And these are his liver tests. Not very exciting, bit of ALT, and the rest of his bilirubin, albumin, and INR is normal. So what does that mean? So what else do you want to know? How about his alcohol intake? He's a baby boomer. And what about supplements and vitamins and his exercise, because he seems to be a healthy guy? So when you delve in a little bit more, he drinks 3 to 4 standard drinks per night, has a brandy before bed, and occasionally binge drinks on the weekend. So that actually works out to be 30 to 40 standard drinks per week, which is excessive, clearly. Maybe. Clearly. Right. And does he have any risk factors for Hep C? Well, he did experiment with IV drugs when he was in university, but he doesn't have any tattoos, and he had a motorbike accident in his 30s and can't remember, but possibly had a blood transfusion. So you're starting to get a flavour for this man who looks really well, turns up at your clinic, has a little bit of ALT, and you're just going to dismiss it unless you pay a little bit of attention. So he's a businessman and he's respectable, isn't he? But he's older, male, he's got a significant alcohol intake and has possible Hep C exposure, so the picture sort of starts to build. So what are you going to do? So you want a little bit more assessment, and I think that's appropriate in this man. And when we look at it, this is what you would ask for. You might ask for his Hep C antibody, which might show past exposure but doesn't tell you anything specific. So you may need to get into some sort of quantitative test, and there are two major tests, the Hep C antigen or the PCR, which would actually show you if this person was infected or has current infection rather than just past exposure. And so this guy turns out to be positive. Chris just gave you a little tour around the hepatitis serology, and I'm just going to repeat that. So he's surface antigen negative, so he's not a carrier, but he's had past exposure, or he's had antibody, and we don't know if that's past exposure or vaccine related, but he's 60, so he's probably not had vaccination at his age, and he turns out to be core antibody positive, which would show you he's had natural infection, which he's cleared. And he's, again, is E antigen negative, so he's got probably no virus in his blood, and his E antibody is positive, again confirming that he's had past infection. And his DNA is negative, so he's not actually a carrier, but he's had past exposure, and that may be important when he gets chemotherapy or something like that, because it can reactivate, for example. But this chap has therefore got significant alcohol history, and he's a Hep C carrier. So what else do you want to know? So he gets an ultrasound, has an echogenic liver, bit of heterogeneous echotexture, normal spleen, no focal lesion, and your eyes are glazing over. But a fibroscan shows that he's cirrhotic, okay, which is what you would have missed on the first take when you walked into your office. So that's the take-home message, just pay attention. A list of common causes of cirrhosis. You all know about Hep B and C. There's this group that we used to call cryptogenic cirrhosis, which is probably all fatty liver disease, and it's probably burnt out fatty liver. That just looks like an unknown cause that we now know that is probably going to be really important in our future. Alcohol and NASH look very similar. And then there's a whole lot of small print things, which are not necessarily uncommon, but are less common, and they sort of get picked up through screening particular blood tests. So those are the things like hemochromatosis, Wilson's disease, and then reducing importance. Autoimmune hepatitis is important, so down the bottom there, but there are some other things like medications and things. So this is sort of the flavour of what we would be looking at, but in decreasing importance, so that viral hepatitis, fatty liver, alcohol are probably three main groups. So the lessons learned from case 1, don't make any assumptions. It is a health check, so opportunity questions may just be important because that might just reveal more risk factors than you would initially have assumed. And ensure that when you do ask those questions, you get enough detail, like his alcohol history. And the reason why we care is that, as I alluded in the first few slides, is that cirrhosis does have mortality associated with it and cancer risk, and is costly. So our next chap is a 47-year-old unemployed. He's got mental health issues for 15 years. He's got depression. He admits to intravenous drug use and is on the methadone program. So you've all made assumptions of what he's got, haven't you? He has got some previous alcohol abuse, but he's been abstinent for quite some time. So not surprisingly, he's got genotype 3. He's fibrotic. He's cirrhotic on fibroscans, and he gets an ultrasound, and he's got a nodular liver, which is the cirrhosis, enlarged spleen, no focal lesion, alpha fetoprotein's a little bit up. You're paying attention? Okay. Platelet count a little bit low, INR still normal, hemoglobin 130. So on the surface it might not ring a lot of alarm bells, but the two things that you want want to look at is he's got a large spleen and he's got a low platelet count. So he's probably got portal hypertension. And what that means is the blood flow no longer flows normally in the liver because of the cirrhosis and is reversed, and therefore the blood is shunted away from the liver, and that's why you get a big spleen and you get varices. And that's important because variceal bleeding is a severe condition and a lot of people die before they get to hospital. So he does need screening, he does need an index endoscopy, and he needs to have surveillance for progression. So even if he doesn't have varices in the first time, he may develop varices as he goes, or if he has small varices, they may get larger. And as I alluded, if you do have a bleed, they've got a 1 in 4 chance of not getting to hospital. And therefore, if they do have varices, we get into primary prevention. So we try and decompress the pressure in that system, usually with beta blockers, and also with endoscopic band ligation if those varices are very big in the first instance, but usually with beta blockers. And secondary prevention, which means they've had a bleed, they then go on and have band ligation with or without beta blockers. And this is what they look like endoscopically. So big veins in the esophagus like varicose veins, and they do bleed. And the third picture just shows we put bands on to try and sclerose them off and prevent those feeder vessels from being exposed to the luminal surface, which is where they bleed from. And when they do come in, they need to be admitted to HDU or ICU. They usually get a medication that reduces the pressure in the portal system. They need antibiotics because they often get infection at the time, so that bleed often causes translocation of bacteria and they get infections which make them sick on top of the bleed, and they get endoscopic treatment. So lessons from this case: when cirrhosis is expected, don't stop. Don't just stop and glaze, or he's got genotype 3, we can't treat him, let's just give up and wait for the new treatments to become available. So think about other risk factors, think about other things we should start in someone like him. Screening for varices, for example, and screening for liver cancer need to be started straight away. So our third case is a 50-year-old Maori gentleman, and he's got a history of diabetes, high blood pressure and cholesterol. His BMI is 40, and he's got a family history of 2 brothers who died in their 30s and 40s. So again, you're going to make some assumptions. That he's a B carrier probably, but actually he's got metabolic syndrome. He's overweight and he's got all the hallmarks of fatty liver disease. He's got hypertension, diabetes and high cholesterol. And he does have a family history of death, so you do need to screen him for HCC if he's cirrhotic, and he probably needs to, the rest of the family needs to be referred to the foundation for screening, because if he's the only one that turns up to your clinic, don't forget about the rest of the family. But fatty liver disease is probably going to supersede Hep B and C, and the numbers are going to make your eyes water because they are huge. So in a population like New Zealand and the US, about 1/3 of us will have a fatty liver, 1.5 million. Of those, about 20 to 30% will progress and have significant liver disease associated with that, 75,000. And many of those will develop cirrhosis, about 15,000. And many of those will develop liver cancer. And in the registries that we're now keeping, fatty liver disease has become the main indication for liver transplantation. So there is a shift. So when we cure Hep B and Hep C, you guys are still going to be busy doing something else, which is this. And the risk of cirrhosis is, there are some clues. So if you have a family member that has fatty liver, and the risk of cirrhosis goes up. So if you have a relative of a patient with NAFLD cirrhosis, they have an 18% of having another family member within their family of having cirrhosis as well. So again, you've got to look at their metabolic makeup, and there's some genetic basis to that. So when we assess cirrhosis, particularly in patients with fatty liver, it's really difficult because they're big, and ultrasound is not very accurate, and neither is the FibroScan. So FibroScan may be good in excluding cirrhosis, but it's poor at predicting cirrhosis. And the CAP score only gives you steatosis. It says nothing about scarring, so CAP may be actually not very useful. So we really need another non-invasive marker as a triage tool, because if we are going to face these kind of numbers, who we're going to see at the clinic, who we're going to let in. So we probably need to have some sort of non-invasive tool to try and see which patients are more likely to be important. So there are some things like the NAFLD fibrosis score or the ELF scores that may become useful. The ELF score is difficult because we don't actually have the blood test that we need to do, but the NAFLD fibrosis score. And we're using this tool now to decide who's going to come to our clinics and then have a FibroScan and a workup. Liver biopsy is still the best tool to give us histology, but in someone that's a BMI over 40, it's quite invasive. You may get a poor specimen and you're no better off, and a liver biopsy is quite difficult to get. So we're going to have to deal with how we triage, how we're going to see this big population. So in case 3, look for cofactors for chronic liver disease. Don't just make the assumption by their ethnicity and their risk profile that they're going to have Hep B. Look for the obvious things, and metabolic liver disease is important and is common. It's a major risk factor and the major cause for cirrhosis, and it's increasingly associated with liver cancer as well. So the 4th case is a lady who turned up to our clinic. She's 45, Cambodian. She's only been in New Zealand for 3 months, and she presents with abdominal distension. And she's got no medical history. So, how good are we at judging if someone has cirrhosis or not? So when you look at somebody with compensated cirrhosis, or just say anybody of you walking in, we're probably less than 50% accurate at clinically figuring out if somebody has cirrhosis, and that's specialist based. So we're not very good at it. If you don't have obvious signs, we often miss it. And even in patients with compensated cirrhosis, the clinicians will use laboratory markers and other imaging information to give us that clue. So not always plainly evident when the person walks in. So when the patient does have cirrhosis, we want to use some sort of scoring system to give us an idea of what's going to happen in the future. So we use things like the Child-Pugh score and the MELD sodium scores, and I'll go into that a little bit. And when the individual has decompensated liver disease, the signs are sort of more obvious and overt, and the laboratory markers will just assist you. So the Child-Pugh score is an old but still useful clinical score, and you can see there it uses 3 laboratory markers and 2 clinical markers. So it uses bilirubin, albumin and prothrombin, and then clinical signs of ascites and encephalopathy. And when you use this score, you have to get a minimum of 5. That's compensated cirrhosis. So you can only use this score in cirrhosis. If you don't have cirrhosis, you don't use this, right? Somebody that has cirrhosis and has compensated disease will have a score of 5 or 6. That's the normal. When they develop complications, either ascites or the clinical complications, the score will go up. And when the laboratory markers change, the scores will go up. And so then you'll get a score of, say, 6 and 7. 7 to 9 will be Child-Pugh, and then 9 and 10 to 15 will be Child-Pugh. And that's important. Remember that first picture I showed you, the first slide, Child-Pugh, 60% of them will be dead in a year. Okay, so the score will give us some sort of idea of their progression over a year. We also use the MELD score, and that's mostly to assess if a patient should be referred for transplantation. But it is important because it shows you as the MELD score goes up, patients will drop off and die. Another way to look at that, if your MELD score is somewhere between 15 and 20, that risk suddenly jumps up, and that's when we refer them for transplantation, because those patients will have a much higher risk. And this is 3-month mortality, right? This is not a year, 3-month mortality. Suddenly 20% at 3 months. So we don't want to miss the boat. So when we see patients, when they start accumulating complications, we need to start thinking about where we position them in terms of their future. When patients have obvious signs, they're obvious, right? If they're jaundiced, or they've got a fat belly, or they've got signs in their hands. So those signs you still need to recognise because patients are still dressed. They might have an ethnicity where it's more difficult to see the yellow eyes. So you need to learn to look at patients and examine them. I think that's an important skill you guys will need to add to your skill set in the future. So I'll just go over some of those complications, how we manage them, just in broad terms. So people with ascites may have a low serum sodium, but in fact they haven't got salt, lack of salt. They have got their normal sodium in their body is in fact high, and they've got water overload, not salt lack. And therefore we actually treat them with salt restriction, which might seem counterintuitive, but it actually works. And we use diuretics to try and get rid of the free water. And when you get rid of the free water, you'll see that the sodium will come up. So these patients shouldn't be given saline in ED because they'll just accumulate more fluid, right? Because they'll just hold on to that fluid. In general, we use a diuretic called spironolactone, and you're actually exchanging sodium for potassium. So that's how you get rid of the water. You get rid of salt in the kidney, and you drag the water out. You can also use furosemide, or both of them together, to do the same. But when that isn't enough, patients need to have a drain in or a shunt put in. In draining their ascites, that's usually hospital-based. We usually drain off as much as we can, and we use albumin in some patients. It's not always necessary. But we must always check for infections because these patients are prone for infections, and if they do develop infections, which is called spontaneous bacterial peritonitis, their mortality goes up. And by itself, SBP is an indication for referral for transplantation because it tells you how far they've progressed. And these patients also then need to have lifelong antibiotic prophylaxis. That's why they're on antibiotics. When that doesn't work, they may need to have a shunt put in. And this is just a diagram of a tip shunt where you connect the hepatic veins to the portal vein and you put a stent through. So now all that blood flow from that was reversed from the liver can get through the liver and back to the normal circulation. And that's helpful in patients with diuretic-resistant ascites and patients with portal hypertension or varicose bleeding that we can't control. So that's a radiological intervention. Also want to talk about encephalopathy because many of these patients do develop this and it can be very subtle. So you have, the principle is that the gut flora will produce ammonia and other metabolites and the cirrhotic liver can't deal with it, and in addition to that the portal hypertension shunts the blood flow, the cleansing of that blood flow away from the liver, and so your brain is affected. So these metabolites are then in your circulation and it affects your function. And it's graded from 0 to 4. Most importantly, 0 and 1 you might not pick up unless you actually look at that person very carefully. And these patients often have difficulty getting dressed and putting up their buttons. That's one of the first signs. They might have a slight smell to them, which is a little bit sweet, almost like renal failure, but it can be much more subtle. And they may have a tremor, and when you cock their wrists back, they'll flap. It's called a hepatic flap. So these are sort of subtle clinical signs that you may look for when you see these patients. You can also do a trail test. So this is a cognitive test of tracing numbers. So you need to connect number 1 and A, then 2 and B. I'm not going to ask you that, but you should normally be able to do that, and children can do this. But these patients cannot do this. They cannot connect the dots. So you can do that in a clinic-based test, and they can't do it. So when they do have encephalopathy, in general, we need to try and avoid precipitating factors, and they get treated with lactulose to try and get them to excrete that ammonia through the gut, so that you give them more frequent bowel motions. When that doesn't work, you can add rifaximin, which may help. Often these patients have been told in the past to restrict their protein, but it's actually not helpful, and I'll show you why later. But you actually need to maintain their protein, normal protein intake. If they get more severe encephalopathy, they may need to come into hospital and they may need to have other things done to them. But it's really important to try and prevent encephalopathy from happening. I just want to cover a little bit on malnutrition because it's often not talked about and often undervalued. But these patients with cirrhosis very frequently have malnutrition, and they have protein malnutrition very importantly. And so there are some assessment tools, and you can use whatever you like, but this is just one. But again, these patients need quite a decent amount of protein because you'll see them wasted around their face and their shoulders because the body's pinching the protein from the muscles, right? And the patients will get more fatigued and they have weight loss. And you'll see in patients who have got compensated cirrhosis, you actually need to give them a decent amount of calories. And as they get sicker, you may need to actually increase the amount of calories per day because their metabolic requirement gets bigger and bigger. And we don't do this well enough. It's only really when they're really bad do you restrict the protein, but only for a short period of time until you get them better over the first sort of 2 or 3 days, and then you reinstitute their feeding. So the message here is don't restrict their protein. So there are many reasons why they lack that. So there's loss of proteins, decreased synthesis in the liver, more loss through the gut, more excretion through the kidneys. They've got insulin resistance and abnormal metabolism in the liver, and there's some other pathways that are involved. I'll leave the slide with you later, but there's many reasons why these patients are malnourished. So it's really important you understand what cirrhosis is and that it impacts survival, and hopefully those scores of Child-Pugh score and MELD scores have given you that flavour. It's important to recognise the signs of liver decompensation, and some of those, like encephalopathy or ascites, may be very subtle, so you need to look for them. Patients will come to your clinic, they've got swollen ankles, and they're a little bit muddled, or their demeanour is a little bit different, so you need to just pick up on those subtle signs that something is not right. And the basic principles is that we can treat these conditions, and it does make a difference to these patients. But that's what the big cost is, right? So once the patients end up with decompensation, they end up taking up a lot of resources and a lot of care in hospital. So our last case is case 5 is Dr. EF. She's a 68-year-old health professional, and she's been under my care for about 15 years. And she's had no treatment for her Hep B because she's had normal LFTs, and I'll show you that although she was a carrier, so she's a carrier, she's surface antigen positive, she's had very low viral load. But just because she didn't need treatment didn't mean she didn't need screening, right? So this lady is not cirrhotic, but she's got Hep B, and I still did regular imaging on her. So she's had an ultrasound, which shows an echogenic liver, but no focal lesion. And later on, she had a CT scan, which showed a small 1 centimetre lesion with no arterial enhancement, and I did an MRI and was indeterminate. And her alpha-fetoprotein was up in the 20s for 15 years, didn't budge. So even though she was cirrhotic, and Chris has told you how important it is in the development of liver cancer, patients who have cirrhosis may have slightly elevated alpha-fetoproteins, and you're going to screen them anyway, but on its own, alpha-fetoprotein may be not enough. So alpha-fetoprotein is important, but it's not enough. It's also important... Sorry? So 6 monthly ultrasounds. So she had 6 monthly ultrasounds and alpha-fetoprotein. And some of those patients, if you're worried and the alpha-fetoprotein is starting to move and you're not sure and the imaging isn't clear, you might want to repeat your imaging a little bit more frequent, just in the occasional patients. But in general, 6 monthly. You can do CT scans as an alternative to ultrasound, but there's a cost involved, there's access issues, and of course if you're going to irradiate everybody every 6 months, that's going to be an issue as well. But it's an adjunctive to ultrasound when you're not sure, or the body habitus means that you're not getting good images, so you need to just mix and match a bit. And you can use an MRI scan, not as a screening tool, but usually as a staging tool. So this lady was asymptomatic. I screened her for more than 10 years, and you might think, oh, well, she's never going to have a problem. And then she missed a scan. She went on holiday. And she came back, her next ultrasound scan, she had a 4 centimetre lesion where the 1 centimetre lesion was previously. So we just not snoozed, she was just not available for one scan. So the MRI and CT then confirmed she's got a hypervascular lesion and a non-cirrhotic liver. The liver's got, the reason why this is important is the liver's got, the tumours have basically occur from arterial supply, so they're hypervascular. So what they'll look like in a CT scan, in the arterial phase they'll look bright, and then in the portal phase and the equivalent they wash out. So they have very typical features. And you don't need a liver biopsy to make a diagnosis of liver cancer, as long as you've got 2 imaging techniques to show typical features. And that's important because this lady is transplantable. And I don't want to do a liver biopsy on her and spread her tumour and make her non-transplantable. So you can make the diagnosis without biopsy. And she's in fact had a TACE, and she's as a bridging for waiting, and she's going to have a resection because she's non-cirrhotic. She doesn't have portal hypertension. So why is liver cancer important? So if we look at the staging of liver cancer, if we pick up the liver cancers early, they have a much better outcome. So this is the Barcelona sort of staging schematic, and I've just used this to show to you, if we find the tumours small and early, they've got a reasonable survival, even if you, and that's because they're treatable. And that's why screening is important. We have to pick up these lesions early. Because if you look at the corollary, if you're waiting for someone to turn up to your clinic and they have symptoms from their liver cancer, nothing can be done, and their outlook is abysmal, right? Their overall survival is less than 3 months. So cirrhosis and screening go together. You have to screen to pick up these cancers early. And this is the same data, but you look at the patients who've got stage 4 disease, at 3 months, more than 50% of them are dead. Okay? So that's too late, and we've missed the boat. So it's really important we screen patients with cirrhosis, and you never stop. And this is just a schematic sort of predictions for New Zealand. This is just based on Hep C, and we can see the numbers going up for liver cancer. And we already know that the main indication at the moment for transplantation in this country is not Hep B or C, is liver cancer. Right? Liver cancer is such an important indicator for. So we need to get in before this all occurs, and that's the point of eradicating these diseases from our communities. So what's your role? Your role is really to communicate well and engage with your local doctors, make sure that the scans happen, make sure that the patients are informed and they turn up for their scans, and most DHBs will do the ultrasounds on 6 monthly basis, but it does need follow-up and needs pushing. We also need to make sure they have got the proper imaging. So ultrasound is a screening tool, it's not a staging tool. So they may need to, if you see a lesion, they need a follow-up scan. They need to have a CT scan or an MRI to actually tell us what it is, because there may be a hemangioma or some other lesion that's not a liver cancer. Or if you see one lesion on ultrasound, when you do the CT, you may see 3. So the ultrasound is just the entry point, but if there's something that's not right, it needs follow-up straight away. And there are local meetings, either at the local hospital, and there is an Auckland HCC MDT every week that we refer patients to. So these patients can be assessed and triaged quickly to what treatment they're going to receive, be that curative or even some of the palliative treatment was, like TACE and radiofrequency ablation will still give them a reasonable outlook. So if you do nothing, that the outcome is inevitable. So these patients do need to be referred. Liver transplantation is a treatment for liver cancer, but it's only really for a small minority of patients. A lot of the patients we get will have advanced disease, even though we are screening, and of course there are some that come much later. But even if they're listed on a transplant waiting list, there are not enough organs to go around. So some of these patients will progress on the list and then have disease that's no longer transplantable. So transplantation is a link, is important, but it's not going to fix the bigger issue. I just wanted to spend a few minutes on the rest of the body. So these patients that have cirrhosis, they also have other organs that are important. And in the presence of cirrhosis, there are some changes that are quite important. Most of these patients will have renal impairment, and that's because they've got, and the reason why that's difficult to assess is they've got reduced muscle mass, they've got reduced protein bulk. And the test for in your renal function is creatinine, which comes from protein. So a lot of these patients will have a normal creatinine, but they may still have impaired renal function. So you have to be very careful. Also, patients who have renal impairment have peripheral vasodilatation and quite marked renal vasoconstriction. So they will be very sensitive to volume change, so to dehydration, and to certain drugs. So you have to be very careful with anti-inflammatories and other drugs, because they may actually push these patients into renal failure when you haven't thought that they might be at risk. Many of these patients have got diabetes as well, particularly patients with metabolic syndrome, which have diabetes mostly, or insulin resistance. And cirrhosis itself causes some degree of insulin resistance. And of course, a lot of these patients have got an altered oral intake, so their diabetes makes you be much more difficult to treat. And often, sometimes their insulin requirement goes down, and that's because they're not eating. So it's a very difficult balance. So you do have to remember diabetes as a separate thing to look at these patients. And a lot of these patients with cirrhosis will be older, and particularly if we look at the metabolic risk factors, hypertension, cholesterol, diabetes, they're all risk factors for heart disease. And in fact, patients who have fatty liver disease are more likely to die from a heart attack than they are to die from their liver disease. So the risk profile is still really important, and we need to pay attention. So I sort of want to give you a schematic of what your role is going to be, because I think it is going to change over the next 10 or 15 years. And Anne, who's not here, from Waikato, her job has changed completely over the last few years. She sees very few Hep C patients because they're now being treated elsewhere. We've treated most of our cirrhotics. So her life has changed. She runs a cirrhotic clinic. She makes sure that HCC surveillance happens. So that's an important role that she's taken on. And particularly the nurses in the hospital base will have to think about how your health careers will change. So you do need to know how to manage cirrhosis. We need to make sure that you're involved in screening for liver cancer, and trigger those index endoscopies when the doctors may not be thinking of it. You need to be showing them a request form for a gastroscopy in patients with cirrhosis. Pay attention to nutrition, and a little plug for the rest of the body, because if you don't look at the whole patient, you're going to get burned somewhere else. And if you have cirrhosis and renal failure, that complicates matters a lot. But remember, these patients are often not necessarily well off, so there are quite some social pressures for these patients often, and they may be financial. They may be quite needy and need a lot of counselling, so they do need time, and they value your time if you spend that time with them. And you need to develop those relationships just like you used to with the Hep C cohort. The cirrhotic patients will stay with you, so it's important you get to know their background and where their hindrances are. And they don't turn up for appointments, not just because they don't want to come, but they can't afford to come. And the parking is abysmal, for example. You do have to form links with other services, so particularly drug and alcohol, and you need to advocate abstinence in all patients who have cirrhosis, because they don't have very much liver left. So if you add a separate insult, that may push them over. So it's not just the alcoholics, it's anybody that has cirrhosis. I would advocate abstinence. And you need to involve other services. So your life may change, so that may include face-to-face clinic visits, and some degree of email availability, communicating results, some clinic follow-up. They don't need to all come back to you, but they are aware that they might be at risk of liver cancer. So when they have their scan, they would like a phone call just to say your scan's okay, because their next visit may only be in 6 months. They don't really want to sit on that possibility. So it's quite important to follow these patients through. And you may want to create some virtual clinics where you have 10 or 15 scans that come through, and you just check that everything's okay, and you then ring the patients and ring them up. Your scan's fine, your next scan's booked for such and such. Just make sure that you continue to close that loop. And you may want to sort of have some contact with the community providers, because that's where these patients live. And it's important to have some sort of liaison role with other services, for example radiology, because these patients may not have turned up for their appointments, and we need to make sure that they come for their 6 monthly scans and find out if they don't attend, why not. And then some degree of role with the MDTs, with the liver cancer MDTs, for example. So there's actually a ribbon for cirrhosis, for chronic liver disease and liver cancer. It's green. So these patients require lifelong care. You can't discharge them. And they need lifelong surveillance for liver cancer. So you may need to remodel your practice for the future, because as we're going to find out, the treatment for Hep C is going to be mostly community-based. So a lot of the bulk of the patients that we will have treated, but anybody that has cirrhosis, we're sort of centralising their treatment in the hospital, for example. And hopefully that will give us a better future. Thanks.
Any questions? Frank, a lot of our delegates here are GP practice nurses. What would you say to them about perhaps being aware of cirrhosis?
Okay, so I used some of the case studies. Some of it is actually catching on to the subtle things. So the lawyer, for example, he might just come. That's the only place he's going to come. He's going to come for his health check that you send him, and he's going to turn up and drink a bit of social, And I think just delving and knowing these patients and delving in it a little bit may uncover it. We can't find them. If they just turn up to hospital with decompensated cirrhosis, well, that's too late, right? So we need a primary care, somebody watching out for these patients and actually finding them, just like we want to find the new Hep C infected patients. We actually want to know those that already have cirrhosis. So they may not be the young intravenous drug users. They're the established people who come to the practice year in, year out for their checks. And there may be an opportunity to see these patients. I think obviously education is important to make sure we look for the obvious causes, and making sure the message about alcohol use, the message about metabolic syndrome, and that's going to be so important in the future. That needs to be go out. So, the engagement of the primary care nurses and doctors is going to be important, because if all we get are those patients who've fallen off the cliff, that's very expensive. We need to do better. We need to find these patients earlier. I think they're waiting for Ed. They were expecting Ed, and they said they got disappointed. He's coming tomorrow.
All right, well, we'll finish a little bit early, so thanks, Frank. Thanks very much. All right, so we have... All right, hope you all enjoyed that little break and freshen your minds. We've added a bit of ad-libbing into the program just because we can. So we've got a little interlude from a lady called Mina Valab, who is here from Pharmac, and it's great that Pharmac are getting more involved with drugs and treatment than just procuring the drugs from overseas. And she's going to speak to us about Pharmac's role in hepatitis C treatment. Thank you, Mina.
Hi everybody. I haven't planned anything, so just excuse me because this is. I certainly didn't have any speech notes or anything to support me with this. Look, you'll all know that we started funding hepatitis C treatments a couple of years ago. And what you may or may not know is that we started with a big bang. We had lots of people being treated, so the curve started up here, and slowly it started going down. And it's not dissimilar to what we see overseas as well. But uptake really matters, particularly when you've got so many health gains to actually, reap from a funding opportunity like this. So we did some research and tried to think about what the barriers were to access and uptake. And one of the things we did find out was that information about people that have been diagnosed with Hep C isn't necessarily available at primary care. And when I say that, it's not readily available. So, when doctors type in details into their practice management system, often those details aren't coded, they're free text. You could describe Hep C in a number of ways, Hep C, HCV, all sorts of things. And then later on, when you try to search for your system about that and try and identify people that have actually been diagnosed with Hep C, it becomes really difficult. So what Pharmac did, was to work with Lab Tests New Zealand and the Ministry of Health and Hep C coordinators to work on a process that would collect all the laboratory information in one place. Once that laboratory information had been collected, we needed to clean that data to make it useful. And we also wanted to match that information that we collected to the most appropriate healthcare provider. And in this instance, we have matched people to the PHOs that they are enrolled in. Then we worked with PHOs to sort of work out what a recall process might look like. And we went out a couple of months ago to each PHO with a letter of agreement, which basically PHOs can sign, and we will enable the right data to get to them. Pharmac is also supporting the administrative parts of running a recall process, because we realise that that's actually, not an easy thing to do. So really, I was just here to tell you guys that, we're doing something to identify people and hopefully get them treated. So far, we have around just under half of the PHOs in New Zealand that have signed up with us to undertake the work. And I'm really aiming for 100%. So if you guys are working in primary care and you're not aware that perhaps the message has got through, then I wondered if you might be able to help at least talk to your clinical leads, and if you have the opportunity to raise it with the CE also, but whoever you raise it with, we would really like to have all PHOs on board to help us get people treated. So that's me. Just wondered if you guys had any questions. One of the things I can do during today and tomorrow is if you want to know whether your PHO has signed or not, just come and see me and I can let you know. Maybe that'll give you a little bit of information as well. So does anyone have any questions for me? Yep. I'm not sure if I can't hear you actually. All genotypes. Now, if you think about the tests that are related to Hep C, there are a number of blood tests that need to occur in order to decide whether a person is eligible for treatment or not. And the laboratory tests collect information on whether somebody is positive for Hep C, but also the other related tests. And so that means that any particular patient may have all of those tests or one of those tests. And so there are a number of different things that will need to occur before anyone decides whether the patient actually needs treatment or not. And so that's why the laboratory data collection is for people that have tested positive, and any other related tests that there might be. Noting, of course, that lab tests are lab tests, but also that we still need FibroScan information and all that sort of stuff as well. It's a little bit of work to do at the PHO level and at the practice level, but we're hoping that at least making the data readily available actually helps people out. So, yeah.
I think a big part of it is people are just probably don't. There's a big stigma against hepatitis C.
Yeah.
And I think that even people going to their GP practices, they still feel that stigma.
Yeah.
And so they're reluctant to go.
Yeah.
And I really think that that's got to be changed big time.
Yeah.
Like, for people to accept treatment, because they just don't want to go and be made to feel like they're, put into a group automatically, and then kind of like they're treated like that accordingly the rest of their time.
Yeah.
So I think it is really important.
Completely agree, and that's certainly consistent with the feedback that we've had from the likes of Needle Exchange that have said to me that that hepatitis C has similar stigma to HIV, or what used to be associated with HIV. So I understand that, and I know that the Ministry are working with the Foundation and HPA on that. That just completely slipped my mind.
Maybe there could be somewhere that, that is in the community that people can go and access treatment in a really safe environment.
Yeah.
And they might want to go and do it more than, just their local GP, and then maybe they know them outside. There's just such a big stigma around it.
Yeah, we if you come and see me at the table, we also produce some information for primary healthcare providers around having a safe conversation as well. I hope that actually helps some people actually do it. But look, it's a really challenging thing to be involved in, and it's a really challenging disease to have yourself, and all that stigma that's associated with it. So hopefully we can all work together and make it better, particularly since there are really good treatments out there. So, yeah.
We won't keep Mina with more questions. She's doing a wee impromptu here, but it's great that Pharmac are here.
Yeah.
And obviously Pharmac are wanting to get bang for their buck in terms of making use of these drugs, so we get the patient outcomes from it as well. So I think, things I'm going to cover in my talk tomorrow, I'm sure Tony is as well in the hepatitis C treatment community, is that this is a community condition now, much more than it was in the past, and it may not be a sexy condition in terms of there may not be a key performance indicator in your practice, there may not be an incentive attached to it in your GP practice, but if you as nursing staff on the coalface can go and nudge your managers and go, hey, look, there's money to be had from Pharmac, that's going to get a manager listening, to find out whether your PHO is engaged. Essentially, we are very aware that it's labour intensive a little bit and that GP practices are thin on the ground in terms of taking the time to go through your databases. So there's help to be had for your PHO. So if you can go and find out with your managers, hey, have you thought about enrolling with Pharmac for this? This is something that you guys can do in a very meaningful way. But, yeah.
Thank you. I couldn't have said it better myself. And if you have any questions, I'll be here over the next couple of days. So come and see me.
Thank you. All right, so our next two speakers are Linnea Matthews and Kerry Kennedy from the Hepatitis Foundation, and they're going to be telling us about FibroScan. So just a little bit more about them. Linnea is a hepatitis community FibroScan nurse. She's been in this role for 6 years, and her background is primarily in primary care, and she has a passion for working with hard-to-reach and marginalised hepatitis C populations, which we've just broached there. Kerry is also one of our nurses, and she works up in Northern from Cape Reinga down to Warkworth. And she also performs FibroScans up in that region, and she's been with the foundation since 2009. So thank you, ladies.
Good afternoon. I'd like to introduce Kerry Kennedy. This well-travelled hepatitis community FibroScan nurse has tripped, not the drug version, through Asia, Russia and Africa. Her former life was as a primary school teacher, then producing 4 children under the age of 5. Oops, I'm sorry, I forgot to do something. There we go. Whilst renovating an old villa. When she grew up in her 40s, she embarked on nursing training, registering in 2003. From emergency care and mental health in South Auckland in 2009, the Hepatitis Foundation gained this superwoman. As a community hepatitis nurse, she covers from Cape Reinga to Warkworth. As a FibroScan nurse, she covers that area and Greater Auckland.
So, despite her youthful appearance, my esteemed colleague over here has in fact been nursing since Adam was a boy. Her vast nursing experience includes, but isn't limited to, community enrolled nursing from 1974 to 1986, mostly in maternity and sex education for the Family Planning Association. So find her later if you have any burning questions in that field of your expertise, or any burning in fact. Linnea then trained as a registered nurse and worked in theatre for 5 years and primary health care for 21 years. She joined the foundation in 2012 and was trained as a FibroScan nurse. She spent the next 3 years scanning patients in the lower North Island and upper South Island. And in 2016, she was contracted out to Compass Health, where she provides fibroscans for patients with hepatitis C. She's become our HCV expert nurse and is the go-to nurse in the field of scanning and educating patients about hepatitis C. Any of your patients who are lucky enough to be nursed by Linnea are lucky enough. And before we go any further, I need to point out that Linnea and I are only 2/3 of the Hepatitis Foundation's FibroScan team. She's going to love me for this. Gillian, would you... Oh, she's not. She's standing right there. Gillian works in the Midlands Bay of Plenty area as a FibroScan and community hepatitis nurse. Do you want to say anything, Gillian?
Hello.
Okay. Right, so the outline of our presentation, first of all, is what is a FibroScan? Everything you wanted to know about FibroScans but were afraid to ask. Who? Why they matter? Do they matter? 3, delivering FibroScans and hepatitis C education in a multiple settings, including prisons and hospitals. Then delivering FibroScan and hepatitis B education in GP and community settings. And lastly, how to get a FibroScan for your patients, why you and your patients want this.
So, what is a FibroScan? A FibroScan assesses cirrhosis and advanced fibrosis with vibration-controlled transient elastography. That's not what I tell my patients. We have a translation. It uses ultrasound waves to give a measure of how stiff or scarred the liver is. Advanced fibrosis and cirrhosis can be asymptomatic, so diagnosis is difficult without the aid of a FibroScan or a biopsy. During the procedure, the patient lies on their back with their right arm extended over their head. Would you want to model that for me, Lydia? We do that to open up the intercostal spaces. The probe is placed over the liver around the right mid-axillary line. A sound wave then passes through the liver. The patient feels this as a bump or as a vibration. The speed that the wave travels through the liver indicates the degree of liver stiffness. The stiffer the liver, the faster the wave travels, so the higher the reading will be, indicating more damage. We have 2 sizes of probes that we use, the XL and the medium. They correspond to specific measurement depths that take into account how far the liver is from the surface of the skin where the probe is held, i.e. how big or how fat the patient is. Stiffness is measured in kilopascals. There is some dispute, but currently a FibroScan is contraindicated in patients who are pregnant, patients with an intracardiac device in situ, and patients under the age of 18. Also patients with large volume ascites, because the ascites can give an unreliable result. The procedure takes around 10 minutes because we need 10 readings, 10 successful readings in the same spot. The results are instant, which means patients can be given immediate reassurance if they're within the normal to mild limits, or they can be appropriately referred to secondary care for further assessment and or treatment when needed. We do our best to obtain a valid FibroScan, but there can be limitations even with the XL Pro. The most common issues that prevent obtaining a valid scan are obesity, with a thick adipose layer over the ribs. I have had patients who have had an unsuccessful scan because of this reason, who've then lost weight and have had a successful FibroScan after that. Patients with COPD, as overinflated lungs can obscure the ultrasound view. Past or present trauma to the right ribs, resulting in deformity to the rib structure and or pain from the pressure of the probe. Very narrow rib spaces and mobility deficits. For example, patients who can't lift their arm up to open the intercostal spaces, patients who are unable to transfer onto an exam bed and unable to tolerate lying flat on their back. The benefits to patients of having a FibroScan in their local community are many. The time, expense and inconvenience of travelling to a large hospital make this impossible for some of my patients. And many patients feel comfortable in small local clinics. They know how to get there, they know where to park, and as travel time is brief, they can fit a half-hour clinic appointment into their busy schedules. No, go back. Now let's talk about what WHO have to say about HBV and FibroScans. Because that was meant to be a surprise. No, not the legendary English rock band famous for Pinball Wizard and Quadrophenia. I checked. They don't have much to say on the topic at all. But this WHO do. The World Health Organization was created by the United Nations in 1948. Their mission is to reduce the burden of disease and poverty and to provide access to responsive healthcare for all people. Sorry, I lost my place. The World Health Organization has a goal to eliminate viral hepatitis by 2030. New Zealand is one of the 194 countries that have signed up to this target. In March 2015, WHO launched its first guidelines for the prevention, care and treatment of persons living with chronic hepatitis B infections. Among their recommendations is to promote the use of simple, non-invasive diagnostic tools to assess the stage of liver disease and eligibility for treatment. And that's what the FibroScan does for your patients. It stages their liver disease and helps assess who needs or is eligible for treatment.
Right, so I'm just going to talk a little bit now about fibroscanning hepatitis C patients in various settings and what we need to consider. So first of all, preparing the environment and engaging with local healthcare staff. Some common factors to all the settings I work in are I just need the basics, a table or a desk, chairs and a bed, ideally one that adjusts for people with mobility deficits. I have safety considerations I have to think of. If possible, I put myself nearest an exit in case I need a quick getaway in occasions of danger. Being aware of signs of intoxication or under the influence of illicit drugs. In my community clinic spaces, I find they need to be accessible and close to public transport. I find physio clinics work very well as a clinic space, nice sort of neutral ground. I inform the reception staff in these clinics that the patients will come and say that they're not here to see the hepatitis nurse, but they're here for a scan because of the stigma attached. The patient's perspective, identifying barriers to care and how best to overcome these. As we've mentioned earlier in some of the other talks, one of the big ones is the perceived or experienced prejudice, being stigmatised or defined by their past or present intravenous drug use. Unfortunately, this is at times within our health service, my patients report, and also some of the laboratories they have experienced, which can be a deterrent for going to do their bloods. There could be financial problems for transport to and from the clinic appointments. So I try and investigate if there are healthcare support workers from their practices or free shuttles that are running by their PHO, especially in the more rural areas. Employers sometimes can be difficult in giving time off for my patients to go to appointments, and patients are concerned that they have to notify their employer about their reason for their appointment. So I suggest things like just saying it's for a medical appointment. Patients need to know what the appointment is about, what is involved, will it hurt? Am I having a liver biopsy? I've had some said that they didn't want to come and see me because of that reason. How long does it take? When do I get the results? Who will get a copy of my results? Am I going to be made to have treatment? FibroScan pamphlets are sent out with the appointment letters to allay these many concerns. The most effective modes of communicating with patients is ideally with a trusted health professional face-to-face. Otherwise, it can be through phone calls, texts, appointment letters, and ideally an 0800 number is useful as many of them don't have credit on their phones if they have any questions. Reminder texts and calls prior to appointments certainly has improved our attendance rates. And most importantly, a non-judgmental approach. A quote I often share with my patients is, "Don't let the mistakes of your past define your future." Points to be considered. Tailoring your information is important in how it is presented to the individual. And it also helps to have a little bit of knowledge of the lingo in the IV drug use world in my job. Body language, including facial expressions. Sometimes you're being told things you were not expecting, or perhaps you didn't really need to know. It's a bit like being in a confessional at times, to be honest. I explain why I ask about substance use or abuse, as alcohol, cannabis, and methamphetamine are all processed in the liver. It can present opportunities also for referral to address any addictions if the patient's in that part of their journey. So we want to avoid this look if possible, especially when they're hearing about their illicit drug use habits. But to be honest, I think a dose of Metamucil will fix that one. So, sometimes inwardly my face is like Cameron Diaz, but I keep it inside. So which clinics work well and why? One of my favourite clinics, I have to admit, Bronwyn, is the downtown community clinic we have in Wellington. This is a new, innovative social health clinic. Many thanks to Bronwyn at Te Aroha Health for instigating and facilitating these effective hepatitis C clinics. It provides a safe, accessible clinic for marginalised and homeless hepatitis C patients in the Wellington CBD. It's a supported social centre, also running the food bank from there. It assists the GPs to work up the patients for treatment. The opioid treatment clinic, we tried running this for a couple of years, but the numbers dwindled to nothing, unfortunately. One barrier is the service is perceived by many opioid treatment patients as a regulatory body for their methadone treatment. However, they do have a large cohort of hepatitis C patients, but they are unfortunately very short-staffed with very heavy workloads. They have great proactive nurse champions working with the hepatitis patients, encouraging them to attend FibroScan appointments. I now see these patients in the community clinics. If they DNA, I email their caseworkers and ask them if they could follow up with the patient. The hospital clinic, FibroScan clinics, these work well in a trusted environment by patients who most often have an established relationship with secondary care gastro services. The FibroScan helps facilitate the patient towards being treated. I can often see large numbers in a clinic as the patient education has been done by our hospital hepatitis nurse champions. The needle exchange, these clinics are in process of being set up in some parts of the central region, as we've been waiting for the arrival of their point of care testing, which is the finger prick Hep C antibody test. There are large numbers of hepatitis C in the current intravenous drug user population. Therefore, we can make a big difference in reducing the pool of hepatitis C in this community through getting them tested, fibroscanned, treated and cured. The prison clinics. I run FibroScan clinics in 5 prisons in the central region. The things I need to consider and prepare for before I go there is, more importantly, not to get a criminal record, have up-to-date clearances for entry, bringing in my FibroScan equipment, etc., allowing time to go through security in the many controlled doors, not to take in a cell phone or any contraband, wearing appropriate clothing not to attract inappropriate attention, not to leave pens, paper clips accessible to patients in case they lift them and use them for other uses, being observant of patients' behaviour and demeanour to keep safe. The guards won't bring up patients who are not in a particularly good mood or bad behaviour. I work with the guards as to the order of who I see due to the transporting from the various cell blocks, as only some can be held in the same holding cells together due to potential conflict. I ask the patients if they have a release date and an address so that we can provide follow-up in the community if it's needed, and to engage with their GP as soon after release as possible. Otherwise, we do find they can be lost to follow-up quite easily. The advantages of the prison clinics are that they are a captive audience, and we can offer education, FibroScan, and discuss treatment options. The hepatitis champion prison nurses explain the benefits of having a FibroScan to their patients, therefore leads to a good attendance rate. Working in so many prisons, for me, enables me to catch up with patients when they're transferred within prison systems, which happens quite frequently. The majority of prison patients are very receptive to information to improve their health.
So we're going to go on a journey of the Hepatitis B FibroScan clinic from the very beginning till the last bit, which is always the paperwork. So first of all, where? I also hold FibroScan clinics in prisons, but the bulk of my work is in the community. I hold FibroScan clinics at GP practice rooms, St John's ambulance stations, physio rooms, small local hospitals, local medical clinics, and a wellness centre where whale song and incense is provided free of charge all day. All I really need, though, is a room with a bed and a PowerPoint. In fact, in the clinics at the St John's ambulance station, I take a portable massage table, so all I really need then is a room with a PowerPoint. Everything else can be worked around. I also hold language-based clinics in Korean and Chinese. Before you look at me with a newfound respect, I have interpreters with me. When holding Chinese-speaking clinics, I have had the assistance of one of our Chinese-speaking nurses, Xiao Ling, and when holding the Korean clinics, the Korean medical centres provide translators for me. So who? A different who altogether. Patients get referred to my clinics in a variety of ways. Our clinical directors, Dr. Moyes and Dr. Lampin-Smith, frequently request FibroScans when patients have blood test results that are concerning and that indicate they may need to be referred through to secondary care. GPs often request FibroScans when referring new patients who are newly diagnosed. Practice nurses and prison nurses also refer for FibroScans. Our community nurses put patients on the list, and I sometimes get referrals from Whangarei Hospital. Due to the length of travel time required by some of their patients, this could be for some of them an 8-hour round trip. And sometimes patients request them themselves. So how? When we have sufficient patients in a particular area, we book a room. Then every patient is sent a letter offering a FibroScan. Those that reply are booked, and those that don't reply, I ring. The patients get a letter advising the date and time of the appointment and a map, and they're also sent our FibroScan brochure. I then ring each patient. I do this for many reasons: to check that they got the letter and intend to come. If they haven't got the letter, I explain the FibroScan and text them the details of the time and the place to go to. If they don't intend to come, it gives me a chance to rebook that slot. To find out if I need to book an interpreter, and if so, in what language. To check pregnancy, pacemaker, and if they previously had a FibroScan. Hepatitis B patients do not need repeat FibroScan unless their results have changed. If the patient cannot attend because the time isn't suitable, I can alter this. And some patients have some real concerns about the scan. Will it hurt? What if the news is bad? We discuss their concerns and they usually attend. On the day before the scan, just in case, they sent a reminder text. I frequently have 100% attendance at my clinics. I like to think it's because it's local and safe and because I've alleviated any fears they had in our conversations. I think many of my patients would say they turned up to get this monkey off their back. So on the day, when I welcome each patient, I shake their hand and introduce myself and share details about my role and my life. I know so much about them, it seems only fair. I then check that their personal details are correct. We talk about their previous blood test results, particularly their ALT and their alpha-fetoprotein. There is nothing like mentioning an increased risk of developing liver cancer to focus someone's attention on what you're saying. This is a chance to explain why those 6 monthly blood tests are so very important and to answer any questions they have about test results and the timing of tests. If they haven't been consented, we do this then. I then ask if there's a family history of liver cancer and explain that if a parent or sibling had liver cancer and hepatitis B, then the patient's risk of developing liver cancer increases. So we will organise a 6-monthly ultrasound scan of their liver. I then check if all their family and household contacts have had their hepatitis tested. This is a good opportunity to explain that well over 90% of New Zealanders with the virus got it at birth from mum or as a small child. This does two things. It explains to them that their relatives may be at risk and might need a test, and it also alleviates some guilt and fear that people have about having hepatitis B. Completely lost my place now. If they are unsure if everyone in the family has been tested, we discuss why this is important and how we can get people tested. However, some people don't feel safe about talking to their family about having a virus, and that's their decision. I check with women if their children had immunoglobulin at birth, if they were vaccinated, and if they've been tested. If they're unsure about this, we discuss the next step, which all the practice nurses will love to hear, is that you call your practice nurse and ask her, because she can check and it's free rather than going to the GP, and that's a real issue for almost all of my patients. We talk about alcohol, kava, cigarettes, marijuana, and the use of other drugs. I check what medications they're on and if they're being seen by a liver specialist. And then we get to the most important part of the appointment. No, not the FibroScan. It's the education flip chart on hepatitis B. We don't have time today to go over the flip chart, but it doesn't just answer questions the patient might have. It answers questions they didn't even want to know. It comes in Samoan, Tongan, Chinese, as well as English. And sometimes while I talk to it in English, my patients are looking at the same pages in their language. I'm a hugging kind of person, just ask my colleagues, and I must emit a vibe that to hug me is okay, because at the end of an appointment, they sometimes do hug me, and they always thank me. Not for the FibroScan result, not for the blood test that I did. They thank me for teaching them about the virus in words they understand and in a safe environment. Recently, a lovely Pacifica man shook my hand and said, "Thank you for your knowing and your telling." And that's what nurses do, isn't it? We know and we tell. Knowledge is power for our patients. Oh, dear. Sorry. It won't come as a surprise when we get to the end anyway. Oh, it's jammed, it doesn't matter. And then finally, the FibroScan, although not really finally. During the education session, we've gone over the process of the FibroScan. They know there's a chance it will be unsuccessful, and they know that I'll probably be able to give them a result immediately. If their FibroScan result shows no fibrosis or mild fibrosis, we discuss continuing on those 6 monthly blood tests. If their FibroScan shows severe fibrosis or cirrhosis, I take a blood test that includes an HBV DNA. And I explain that I'll arrange for an ultrasound scan. I stress that it's different to the FibroScan, and it's really important they turn up for that, so that when and if they're referred through to secondary care, the liver specialist will have a lot of the information that they need. I also advise them to avoid alcohol until they've seen the liver specialist, and I let them know that the FibroScan result may be artificially elevated, particularly if their ALT is high or if they're obese. And then it's paperwork time. Dependent on the result, I request our clinical directors review the file and consider referral to secondary care. I write to the GP and the patient's specialist if they have one, explaining the results, what the next steps are. I include any details of any blood tests that I took on the day, and I let them know if I've ordered an ultrasound scan and any concerns that the patient might have. And finally, making a difference is probably the reason that everyone in this room is in healthcare. So here is our take-home message. The virus can shorten your patients' lives and reduce their quality of life. In most cases, regular monitoring, timely interventions can prevent liver damage and improve health outcomes. Early diagnosis, efficient management, and correct treatment for patients with hepatitis B will reduce the risk of liver cancer by over 50% in just a few years. And that's a powerful difference to make. So it's good night from me.
I haven't done the referral.
We honestly did practice.
Right. Before we say good night, so where do you go to refer patients for FibroScan in the central region? This is hepatitis C referrals I'm referring to. For patients in the 3DHB area, which Wellington, Wairarapa, Hutt, you refer to 3D health pathways. For the rest of the central region, it's through the mid-central region's local pathways, which has just recently changed, so I've got the updated link there. You can send through referrals to order Compass Health. They're the contract holder, and that can be electronically if you have an outbox document in the MedTech system, for example, or by fax. All the links for all the referrals are also in one place in the Hepatitis Foundation website under Health Professional tab in the Hep C section. So it's a one-point, stop, really. Now, it's good night from me, and it's good night from her. Thank you.
Any questions at all? We thought the good night would alleviate that.
penny DNA rate? I know you do a lot of work, right?
Yeah, I don't think we ever calculated it, but I do frequently get. I thought you were offering me a drink when you were doing that. I do frequently get 100% attendance, but that is simply because a massive amount of work goes in from the office and from me to get them to turn up, because it's such a waste of time and effort. And you know, if I'm away from home, it's accommodation and all the rest of it. So we really do try to jam them in, and we have a very good attendance record.
Is it with Hep Bs?
With Bs, that's hepatitis B.
Yeah.
Now you
Hepatitis C. Yes, the rates have been a challenge, but we're working on different ways of improving that, and a lot of it's through our communication style we're using has certainly improved greatly, and making contact with GPs because patients can change phone numbers and addresses quite regularly. So that's certainly on the improve. Yeah. But I don't have data, sorry. Oh, there we go. Jenny can talk to you about that one.
In Christchurch, I can only talk about Christchurch really, and Barb will probably talk about. But
Jenny, there's a mic.
But we have a couple of pathways in Christchurch. One is through a similar clinical pathway called Health Pathways, and that recommendation is to go through to gastro. And Jess here does FibroScans in Christchurch Hospital, and Gina and Judith do the prisons. GPs often refer to the community clinic, and we run 2 days a week, but looking at a third to go out to cause to try and get our Gino 3s prepared. Pass you over to...
In Dunedin, I'm Barb Smith, manager of the Needle Exchange in Dunedin, and we have a free GP clinic there every week, and we have referrals coming from that to a fibroscanning clinic that comes on site once a month with the clinical nurse specialist from Dunedin Hospital, Margaret Fraser, bringing her portable fibroscanning mould, and we have very good attendance rates at that as well. So, yeah, quite well serviced in our area. And Southland?
I'm Jodie, I'm from the nurse in Southland. We have fibroscans once a month. We get the probes sent down from Dunedin for a few days of the month. So we have fibroscan clinics where we just try and get everyone in, from GPs, from prison, from all sort of services. And the clinics that I do, I try and book any new patients that will potentially need a fibroscan to have it done at the same day. So, yeah.
Sorry, I also meant to tell you that Judith goes over to the West Coast and fibroscans over there, Westport and Greymouth, that's Judith and Secondary Care, and I cover Ashburton and Kaikoura.
Thank you.
Kia ora, I'm Gillian, and as you know, I'm the baby of the FibroScan nursing team, as they like to refer to me, but I said, can you please not do that in front of everyone? So, I scanned for the Midlands area, and I didn't know what that was when I started, but basically it's the Bay of Plenty and it goes wider. So that's Midlands, and it's just down the hill from these guys and up the hill from Lanier, from Kerry and Lanier, who have basically taught me mostly everything I know about fibroscans, so thank you. And a few other things about life. Yeah, that's good. I'm working currently with Helen, who's been in the industry 30 plus years, and she's teaching me hepatitis B nursing in the community, which is amazing, and it's quite complex and different. My lovely team at Waikato, who I was working with recently, fibroscanning for Hep C, and of course our clinicians at the foundation, Alex and Chris, who are basically the godfathers of everything around Hepatitis Foundation, and everybody else. But I just wanted to hand over to how you refer to for Hep C is with my friends here at Waikato Hospital now. So I'm fibroscanning Hep B only in the Midlands area. So I'm just going to hand over to Nancy, who's looking after that. That's a big Joe.
Hi, I'm Jo Delisle from the Midland region. So we look after Lakes, Tairāwhiti, Waikato, Bay of Plenty and Taranaki District Health Board region. So to refer for a fibre scan there, we use BPAC e-referral. So every GP in those 5 DHBs can electronically refer for a fibre scan, and they can get an electronic response directly back. So that's just a new little feature. So they can get a fibre scan result and a suggested management plan. And Gillian's handed over the gauntlet to Nancy Carey to my right, who is a fibre scan nurse working around the region, so attending around the prisons and all the community groups. We've just started fibre scan clinics within the needle exchanges. We've got 4 needle exchanges in the region, so we've got one in Mount Maunganui. We've just had our first one in Hamilton, which was just such a cool clinic, and visited Rotorua, and then we're going down to New Plymouth. So we've got fibre scan clinics there as well. It's a very community, and you can also, for those who don't have BPAC e-referral, we have a manual form that you can refer in, so that's for intra-DHB and for secondary services if they want to refer to fibre scan.
Alright, that ends day 1. I hope you found it useful and mentally stimulating. We've now got some nibbles and canapes and drinks just to celebrate the war here, thinking about hepatitis. And if you've got any questions about anything, you can approach the speakers or any one of our staff in the lovely t-shirts. Thank you.